Hello, everybody, and welcome to our webinar today. Thanks for joining us. For those of you who don't know me, my name is Sue Verrilli, and I'm the Regional Education Coordinator for the Northeastern Ontario Stroke Network. As you may have noticed, I've hit record. We're going to record this webinar, and I'm going to put it on our Northeastern Ontario Stroke Network YouTube channel so people can access it in the future, especially for those that couldn't make it today. I'll remind you to mute your microphones while Margot is speaking. You can put your questions or comments in the chat, and I will be monitoring that as well. We'll have a few moments at the end of the webinar today to ask some questions, so just keep that in mind. I will send out an evaluation survey. I've added the link to the meeting request today. It only takes 1 or 2 minutes. If you could quickly do that at the end of the webinar, Margot and I would really appreciate that. As well, we'd like to send certificates of attendance. So if you can just rename yourself by going on your picture, clicking on the 3 dots, renaming and putting your full name in, and adding in the chat anybody that might be viewing this in the same room as you, then we'll be able to track down your email address and send some certificates out to you after this event. So I'd like to introduce our speaker, Margot. Welcome, Margot.
Thank you.
Margot is from the Southwestern Ontario Stroke Network. She is a social worker by background and works in the role of Community and Long-Term Care Coordinator, a role that I once shared with her for a number of years. We did a lot of fun work together. So I'm really pleased that she could join us today and talk about behavior change post-stroke. Welcome, Margot.
Thank you, and thanks for having me. Always nice to share some information. It would be better in person, obviously, but we'll take what we can get. So I'm going to move right into just kind of our takeaways for today so that people have an understanding of what we're going to cover. We're going to look at the effects of stroke on behavior, the areas of the brain that are impacted, specific changes to behavior that can result from stroke, and as well as strategies to manage them. We're going to look at possible triggers that can bring on certain behaviors, and then we're going to talk about some resources that are available for you. So as a healthcare provider working with people with stroke, it's really important to understand the effects of stroke and how it can affect people, their behavior, how the brain works. And then once you have an understanding of that, you can better support the person who has had a stroke as well as their family. So when we talk about the effects of stroke, there are several. And I might also preface this just by saying that I'm going to, because there's a number of you on today, and I know there's a lot of different, therapists that are present, I'm going to kind of speak from a point where some of this might be obviously like you might obviously know a lot of what I'm covering, but I want to start at a baseline just for those people who might not be as familiar. So when we look at the effects of stroke, there are several. Today we're going to focus on the changes in personality and behavior. So the impact of stroke on behavior, it depends on a number of things. It can include where in the brain that the stroke was, how severe it was, how long ago it happened. And it also depends on how the survivor behaved before the stroke. And sometimes people forget that they need to really consider that as well. When we look at stroke and behavior change, it is typically strokes that happen in the temporal or the frontal lobes that cause those emotional and behavior changes. But they can also be a result of the cognitive or perceptual deficits that people experience after a stroke. Again, this is pretty typical for someone who works in stroke all the time, but just to remind people that the brain is divided into 2 hemispheres. The left side of our brain controls the right side of our body, and the right side of the brain controls the left side of our body. This is just a picture of a brain to kind of bring it home for people. You can see the yellow and the red are the frontal and the temporal lobes. And that's where our thinking, memory, behavior, as well as learning and feelings are controlled. So it's typically strokes that happen in these areas that bring on a behavior change post-stroke. So when we look at the impact of stroke on behavior, it's important to know that changes are not going to be consistent. There can be good days, bad days, or good times during the course of the day, as it is with any of us. So really helping the family understand those changes and why they're happening are very important. So that the damage really can make people react in ways unlike their pre-stroke personality, and family members are not always aware of that. Stroke and personality. Stroke can change a person's personality, and this is a very difficult thing for, especially for the caregivers, the loved ones, the family members, because the person seems changed. And because personality is what we connect with, these changes can really cause the person with stroke and their family member to feel that sense of grief or loss over what they used to be like. I often recall a time where I visited a couple in their home following a stroke, and the husband had been, the life of the party, always the one telling jokes and laughing. And after his stroke, he had a very flat affect and hardly spoke at all. And I just remember the pain that his wife felt. He was physically well, he was alive, he survived his stroke, but he was a different person. And so we really need to help the stroke survivor and their family members understand why these behaviors and changes are happening, and to help them adapt. Fortunately, time is on our side. So as with many deficits following a stroke, the good news is that things can improve over time, and that includes behavioral and emotional changes. So as people adjust to their new normal, that can also improve things for them and their loved ones. So right now, we're going to go into specific examples of behavior change. And the ones that we're going to look at today include, I'll see if I can bring that up, emotional lability, depression, fatigue or apathy, anxiety, impulsivity, anger and aggression, and social isolation. So these symptoms are distressing not only for the person who's experiencing them, but as we mentioned, as their caregivers. And so the important thing for us to remember as people who provide support post-stroke is that they can not only negatively influence a person's quality of life, but they can also negatively impact their clinical outcomes. So unfortunately, when the disturbances are emotional and not physical, they're not always as apparent and therefore not as easily noticed by clinicians. So we'll start with emotional lability. Sometimes people refer to this as emotional incontinence. And it really is when those people who have had a stroke have responses to things that are very excessive, or they don't match the emotions that they're experiencing. And so this can be really confusing, and not just for the person with stroke, but for whoever they're interacting with. I was a social worker for several years in a long-term care home. And when I talk about emotional lability, I often think of a resident that I worked with a lot. And she had aphasia as well as emotional lability. And so it was very hard for her to make people understand when they walked in a room and she would start crying that she wasn't sad and she wasn't upset. And the more time I spent with her, obviously began to learn these things about her. But it was very difficult at first. The fact that people, when she was happy to see someone, she actually started crying. And until you understood her and her responses, it was difficult to understand what the tears were about. These are some other examples of emotional ability. You can see the one in the middle, the mixed emotional outbursts, laughing that turns into crying. That was her. What on earth is that? Oh my gosh, guys, sorry, I'm having a document recovery issue. What is happening? Let's see here. Sorry about this. I have no idea what happened. Are we seeing it back again, Sue?
Yep, it's all good.
Okay. So these examples of emotional ability, it can be very different for people depending on what they're experiencing. Definitely really mixed emotions and inappropriate reactions to situations are common. So before I go on to the next slide, and Sue is going to be monitoring our chat, I'm just going to ask people if they can think about a few things that might trigger someone to become emotionally labile. And you can just pop your answers into the chat. Give people a couple of seconds. Okay, I don't see too many chats, so I'll move on. So these
Somebody
are
said, just to let you know, Margot, somebody said talking about their disability or maybe having pain or asking about their own family.
Yep. Yeah, so those are all, I mean, these triggers are not exhaustive by any means, the list, but certainly things like fatigue and stress and worry can be a trigger. High levels of sensory stimulation where people just become overwhelmed can also bring on some emotional responses. People demanding certain things that are difficult for the person to perform. When we think about the lady that I referenced and the fact that she had aphasia, it was always very difficult, and she would become very emotional when people tried to communicate with her because she had such a challenge doing that. Also, just things like discussing things that are very emotional, as someone mentioned, things like relationship issues or grief or loss, as well as very extreme situations like very sad or very funny situations. Those can also be triggers. Well, how can we help? And that's what we're here to kind of learn, is when we're experiencing, when our patients, our clients, our residents are experiencing this, how can we help? So the first thing is to really find out if their feelings that they're having are matching what they feel on the inside. So for example, the lady that I referenced, she would be so happy to see me when I would come in to visit, and she would start crying. Until I learned, I didn't understand. So we really have to ask about those, the matching. We also want to encourage them to slow down, take some deep breaths, explain to the survivor and their family member that it's a common occurrence after stroke. And we don't want to tell them to stop, because this could just lead to further frustration. The best thing is to really try to distract them and help them gain control of their emotions through distraction. Sorry. The next topic we're going to touch on is depression. And depression is very common after a stroke, and it's most common in the first year. In fact, research shows that it typically occurs in the first 3 months after a stroke. However, it can happen at any time. I think everyone's aware of the need for a person to be screened for post-stroke depression. That's in our best practices. And the other thing that the best practices mention about depression is how the symptoms can resemble depression that's triggered by other causes, but post-stroke depression has some differences. And they point out that stroke with people who have experienced the stroke with depression experience more sleep disturbances, vegetative symptoms, and social withdrawal. So again, that was from the best practices, which was actually something new that I learned quite recently. You might want to keep that in mind as far as post-stroke depression. We all know that after a stroke, it's very normal for people to have a sense of loss and some sadness. That doesn't mean that the person is depressed clinically. So real depression is a chronic, overwhelming sense of sadness or loss of interest and despair that actually interferes with their ability to function. So it's not just having the blues. And these are some symptoms that I'm sure most of you are familiar with when we look at someone who might be experiencing depression. So as far as how we can help, studies have shown that social support is probably one of the biggest things that we can do to help someone with depression, and promoting time spent with families and participating either in, social groups or organized groups or peer visiting programs is a really important aspect of supporting someone with depression. We also want to really encourage people to talk to their doctor, because we're never sure until we actually get a medical diagnosis, and you can't actually treat depression until you know what you're dealing with. Sometimes medications that people take following a stroke can make people feel tired and lethargic, and it can look like depression and feel like depression, but actually isn't. So that's why it's really important for them to get a medical opinion. The other thing, when you're talking about trying to feel better after depression, I know we all know this, exercise is a big one. It helps us feel good, and it releases those feel-good hormones, and we're all supposed to be doing it, but it's even more important if you have someone who's suffering from post-stroke depression. The next behavior change we're going to talk about, and I grouped them together, and it doesn't mean they're the same, but a lot of the responses and the strategies to manage fatigue and apathy are the same. So I did lump them together for those purposes. Apathy is when you lack motivation, so it can look very similar to post-stroke fatigue. People may lose interest in life and not want to take part in everyday activities. And apathy can be fairly common after a stroke, but it's more likely to affect people that have had severe physical or cognitive deficits following their stroke. The other thing is that apathy can be a sign of depression. So we have to know, is it part of depression, or is it happening on its own? Probably one of the most important things we can do here as well is getting people participating in activities that can improve their quality of life and also improve their self-esteem. You can see here that apathy is quite common. It's reported to occur in between 29 to 40% of people who've experienced the stroke. And so when people are feeling apathetic and lethargic and tired, it can really negatively impact their recovery. So we want to make sure that we're addressing those symptoms. So how do we do that? So with fatigue or apathy, it's really important to investigate why it's happening. And so we've talked about the fact that it could be post-stroke fatigue, it could be coupled with depression. So we need to manage those contributing factors. We also want to encourage them to speak to their doctor, because as I mentioned, some medications can contribute to fatigue. We really want to reinforce the interest that they show in particular activities, but we also want to make sure that they're enjoying them at a time of day when they're, most feeling the best. So for some people that might be more early morning, other people it might be later in the afternoon after they've had a rest. And we can also encourage them to break their activities into smaller tasks so that they can have some rest in between. Again, exercise I think probably exercise is one that's going to get mentioned a lot here because it does just have so many positive things that can come out of it. And even if a person is tired, you can suggest they try to get even just a little bit of exercise every day. And then the whole piece around education, both for the stroke survivor and their family member. Fatigue after stroke is really not understood very well. And so it's important that they understand that it is a cause, that they're not just all of a sudden deciding that they're not wanting to go out and attend events or things. The best response to apathy is activity. And so giving people a choice in things that they can do is probably one of the best ways that we can help. The next one we're going to talk about is anxiety. And anxiety can also come with depression, or it can happen on its own. But it does affect around a quarter of persons with stroke and a third of people who have had a TIA. Again, when people are anxious, it can really have a negative impact on their rehabilitation efforts and prevent people from returning to activities that they enjoyed. Anxiety can also be because of psychosocial factors or biological changes to the brain. So again, helping families and stroke survivors understand why those changes are happening is an important part of what we need to do to educate them. People who are anxious can really find it difficult to calm down. They can feel worried most of the time. They can have panic attacks. They might have reoccurring thoughts, and they might tend to avoid situations. As I mentioned, depression can happen, anxiety can happen as a result of depression, or it can happen on its own. But it's important to note that anxiety is more than just feeling a little bit stressed. So post-stroke anxiety, the best way to identify how to treat it is to take into account other conditions that they may be predisposed to and how those conditions relate to anxiety. Some of them are listed here, but when you think about the fact that a lot of people have post-traumatic stress disorder following a stroke, that they're afraid that whatever they do or wherever they go, that they might have another stroke, that there's grief involved. And we talked about some of the reasons that they may be experiencing loss or grief, depression, sleep disorders, fatigue. There's so many other things that can also impact post-stroke anxiety. So what do we do to help when someone is having those episodes of anxiety? Basically, education again, just really educating them around things that can make their anxiety seem worse. And those can include things like caffeine or processed food. We also want them to seek out information, because by being informed, it takes away the fear that arises from the uncertainty and gives them some control over their situation. We also want to promote good things like exercise, again, journaling, listening to music, meditation, mindfulness. All of those things can help people relax and feel less anxious. And again, always encourage people to talk to their doctor, because anxiety after a stroke could be caused by damage to parts of the brain that control emotions. And in some cases, medications may be beneficial. And the next behavior change we're going to speak about is impulsivity or lack of insight. So sometimes after a stroke, an existing personality trait can become exaggerated, and it can result in poor social judgment. So persons with stroke may have less or even no control over decisions they make, or actions, or the words that they use. They also might not be able to understand the limits of their abilities. And this is a common one. So for example, people might not recognize that their weak leg makes it unsafe for them to walk alone without a walker or a cane, or they might move too quickly when transferring that might place them at risk of falling. Those are just some things that can happen around impulsivity or lack of insight. I know one of the ones examples that I like to give is a woman that I knew who had a brain injury, and she went out, one of her first outings where she went out on her own, she needed to buy underwear. And she bought, I can't remember the exact amount, but it was something like 30 pairs of underwear. She knew she needed underwear. But she, her impulsivity, or I guess it would have been more of her lack of insight, just led her to buy far too many pairs of underwear. So how can we help someone who's showing signs of impulsivity and having poor social judgment? Well, we want to make them aware that they're being inappropriate. Just, straight out inform them in a reasonable manner that, wow, 35 pairs of underwear, it might, be more than you need. We also want to recognize limitations and risks and try to minimize them. When they do show appropriate behaviors, we just want to reinforce those, and we want to remind them of their limitations. So the example that we gave about the weak leg and then needing to use a walker or cane, we want to make sure that family is informed and that the impaired social judgment is likely caused by the stroke. And so now we're going to talk about anger and aggression. And after a stroke, some people just experience anger more frequently, and they have less control over their outbursts. They can get angry over things that wouldn't normally bother them. And unfortunately, that anger is often directed at family or for those that are caring for them. So it's important for us as healthcare providers to make sure that the family knows that these behavioral changes and the anger is not attention seeking or anything else. It's a result of the stroke, and it might be the person's way of communicating their needs. So I jumped ahead again there. So I wanted to ask people about some of the triggers that they may have seen for anger or for aggression to happen. What might trigger someone to feel angry?
Okay, we'll give them a few minutes to type it in the chat.
Yeah.
Someone's saying being unable to do something that they wanted to do. Losing their license, isn't that a big one?
That's a big one.
Someone who's speaking for the patient and not providing time and opportunity for the patient to express themselves. Someone that's just trying to speak.
Okay.
Those are all good.
Yeah, again, not an exhaustive list, but here are some possible triggers for anger and aggression. And I know some of these were mentioned. So yeah, trying to do something that's become more difficult. I had a gentleman who always wore dress shirts, and he wasn't able, after his stroke, to button the buttons on his dress shirts. And it was the one thing that just really it was his goal, was to get back to doing up these buttons, but he could become quite angry and frustrated when he couldn't do that. I think we all know that when we're tired or we're in pain, that we can be grumpy, and that's just a normal part of how we react to those things. We can be overwhelmed by too many people, too many noises, too many distractions. It might be that we're having trouble communicating, or we're being pressured to perform or to speak. And it might just be that we're not able to take part in something that we enjoy. So you think about somebody who's unable to drive or unable to play golf any longer. It can really bring on some anger. So how can we help? Not sure, Sue, I'm hearing an echo now that wasn't there before, but I'll keep
it's
I'll
good. I just muted someone. It's all good.
Okay. So So first of all, we want to identify the triggers. So we want to look for the clutter or the overstimulation or whatever it is that's causing the anger. We want to look for what the reason behind it might be. And for sure, when we think that someone might be experiencing pain, we want to identify that so it can be treated. We want to learn the person's preferences and routines so that we're doing things in a way that keeps them, positive and experiencing things at their rate and at the times that they like to do things. We also don't want to alarm people by approaching them on their affected side, and offer support or assistance as needed during activities that can cause frustration. So for example, if the person is having difficulty communicating, you would want to do things like, use your skills in supported conversations, bring out a pen and a paper or a pictograph, something like that. So, think about what it is that they're struggling with and offer as much assistance as you can. No matter what we do, people may still become angry. We can use all of those strategies and they still may have an outburst. So what do we want to do during an outburst? Well, it's important for us to stay calm. When someone else is angry, it can get us, feeling a little anxious ourselves. So we want to remember to use a calm approach, remove them from a situation or activity that may have triggered the outburst. So maybe there's loud noises or activities or some people that are disturbing them. We want to redirect their attention somewhere else. So to something that they enjoy, maybe, a favorite television show. But we also want to make sure that we stay safe, because if the person becomes violent, we want to make sure that we've given them space and then report, the incident to a staff or a team member if needed. So these are just things to keep in mind, because we know that we can't always keep people from becoming angry or aggressive. It's also really important to make family aware that they should make sure that they follow these, little tips and tricks, and to make sure that they also stay safe and make sure they remove themselves if they feel like they're going to be harmed in any way. And then the last one, I saved social isolation for the end, because I feel like all of the other ones that we talked about can actually be a reason that someone wants to self-isolate. So a stroke brings on many changes, and adjusting to them can be really difficult. So sometimes people have develop a poor self-image or low self-esteem, and they may cope with these feelings by isolating themselves from social activities and from their loved ones. But social isolation can also occur for reasons such as being unable to drive. So they can't get out, they can't, visit their friends at the coffee shop like they used to. They not only can they drive, they don't have access to transportation. Perhaps their house has several stairs and they're not able to get out on their own. So as much as social isolation can happen because of, having to adjust to things like behavior change, it can also be a result of environmental factors. Well, how can we help people that have become socially isolated? We really want to learn about them. So talk to them, talk to their family, find out what they like, what activities they enjoyed, and give them a chance to talk about them and experience their past experiences and their and memories. We want to be supportive and encourage them to talk about their fears and concerns. Sometimes it could just be something physical and they're embarrassed to say, well, I don't really want to go out. I've got facial droop. Sometimes I drool. Those kinds of things can be very uncomfortable for people. So they might not be feeling like they want to get out and participate, but we need to encourage them. And also we need to promote independence, help them achieve confidence and greater self-esteem. And then looking for ways to overcome barriers so that they can get back to enjoying those things that they loved. And that's where your your rec therapists, your other team members can, help you be creative as looking for ways to, how can someone, if they used to like to play cards and now they, can't see them or can't hold them properly, is there something we can create? Are there some kinds of tools that can help them overcome those barriers? And so as social isolation was our last one, I just wanted to move into some key points for us to remember following today. And just that the fact that as healthcare providers, understanding these changes in behavior can really help you support the person with stroke and their caregivers, and to give them that sense of hope that there's always, with time that things can continue to change and improve, and that there are treatment options and coping strategies available that can help. So when we look at those coping strategies and treatment options, I pulled out a couple just to kind of share with you here today. So these are the ones that are most highly recommended for behavior change that happens after a stroke. They talk about cognitive behavioral therapy, behavioral management training, of course, medication for certain things. That would be under a doctor's supervision, and then also family and caregiver support, and just encouraging them, both the stroke survivor and their loved ones, to talk about their feelings. These are some strategies when you're looking at working with someone who is experiencing behavior changes that can assist you in providing that support. So that support can come with the help of your team, with some doctors, with those different types of therapy. But we also have resources that are available to us. So I'm not sure if all of you are aware, but we, as a stroke network, did create what are called the core competencies for stroke. And there is a social work specific one, and I've put the link here. It basically takes you to a whole list of learning resources that are important for social workers to know. But there's also ones for OTs, PTs, nurses. Sue, I think probably I'm leaving out somebody, but
recreation therapists, dietitians, nurses.
Yeah.
There's
Yeah.
6.
So whatever your line of work might be, you can potentially bring up the core competencies there. There's also some recommendations around the Canadian stroke best practices, in the Canadian stroke best practices around behavior change. And Heart and Stroke also has some quick reference guides, taking action for community and long-term stroke care. They're basically 1 to 2 pages that just kind of give you a quick down and dirty around ways that you can provide support. There's also the healthline.ca, and that's a website that takes you to what we call a stroke microsite. And you can basically find all kinds of different resources there. You can plug in a person's postal code so that you're bringing up things that are, close to their home community. So basically the healthline.ca is a website that is specific to the legacy LHINs. So in my region, we have a healthline site and a microsite for the Southwest LHIN, for the Erie St. Clair LHIN. So I'm not sure if they're going to change them now with how things are with Ontario Health, but right now that's the way that they're set up. And then there's a final link just around personality changes post-stroke that the American Stroke Association has put out, which I have found helpful as well. I know Sue said she was going to send out the slides. She can maybe send out the links to these as well. But does anybody have any questions about them? Or we've got time. I don't know if somebody would like me to bring up the helpline and kind of show you that if you're not familiar with it.
Yeah, I think if
whatever.
you wanted to click on the health line, we're the Northeastern Ontario Lynn, and so it's Lynn 13, and we've lost our stroke button. It's not back on there yet, but
Oh, really?
yeah, so I think this
Okay, so what did you
website
say
is
you are? Where did you say?
13. Just go on the map. Yep.
Go. Okay, sometimes the stroke button is way down here.
No, we've lost ours. We're hoping to
Really?
get it back.
Okay, well, without a button, all you have to do is type in stroke and should come up here. So you can see here, I'm just gonna make my page a little smaller there. You can see here, we've tried to make it aphasia friendly. It's got all these different headings. You would simply, well, one of the things you can start out by doing is choosing up here on the tabs. So say you are in the Algoma region, then you can go down here to My Health. Maybe you want to look at stroke and depression. And so this is where all of the links that would come in that would be related to stroke and depression. Taking my medication, let's just click on one. So support groups. You can see here, there's a young stroke survivors group. March and Times has some groups, Heart and Stroke. And you can add things to a clipboard up here. Yeah. This one on pain. So this takes you to the services that are available. You can see here, I clicked on Algoma, so it's bringing us up those resources. But you could pick another section, another area. Okay. And again, sometimes, I'm just going to go back to the main page, because sometimes we get calls or we have family members that live in our region, but they actually have the loved one that had a stroke is in another region. So if you go to the healthline.ca, you can, somebody might be calling from your region, but their loved one lives up in Central. So you would click on Central, and then you'd be able to help them navigate services in that area. And most of them do have here's an example of what the stroke resources button looks like, even though yours was missing. Oh, and this looks different on here. Look at this, Stu.
Yeah, they've been updating things, I guess. It's good.
They've made it more, yeah, they've changed from kind of pictographs to real life pictures. That's interesting. I've never seen that.
If we have a minute, maybe we could also go to your resources from your slides, the ones you like from the American Stroke Association.
See if it will come up. Oh, it's saying it can't. PowerPoint can't download the information.
Want to just type it in your browser?
Yeah. Let me get out of here. There we go. There we go. Again, I'm going to try to make this a little smaller.
Okay,
Oops.
thanks.
Yeah. So this one has just some good articles and some information for the stroke survivor or their loved ones that could be helpful. So they talk about depression, grief, intimacy, things like that, post-personality changes, mood disorders.
Very interesting, thanks.
Did anybody have any questions, or did
Yeah,
they
if you
want?
want to go back to your PowerPoint, I'm not sure where exactly you were.
Yep. So my next slide was going to be, questions.
Okay, so we have a number of questions. I'm going to start with some of the written questions. Have you heard of or speak at all about post-stroke psychosis, where a person presents with paranoia, hallucinations, and delusions? Are you aware of anything around that, Margot?
I am not. And it's funny because I was telling Sue that the behavior change presentation that I normally give is for line staff in long-term care homes. And so when I was doing it for you guys, knowing that there was, quite a wide range of different professionals, I was doing a bit of research and I didn't come across anything about that. So no.
Interesting.
Hmm. Is someone like, has someone actually had to experience with a particular patient or client?
Not sure. Erin, did you want to unmute? Oh, she said she had a client recently diagnosed with this by a psychiatrist. Very interesting, Erin. Thank you.
And I wonder if it was strictly like a result, like was it after the stroke, or did they have any of those symptoms prior, I wonder?
Yeah. Do you know, Erin, if it was related to their stroke or if it was no symptoms prior? Interesting. You have to Google that and see what you can find out or look at the resources. Marlene is saying they had someone in their area too, a young woman with no symptoms prior.
Wow.
And Erin said the doctor stated it was caused by the stroke.
Wow.
Yeah, very interesting.
Yeah, it is. Might be something we might want to look into a little further.
Yeah, same for her, Marlene's patient as well. All right, thank you. I did put in the SurveyMonkey link for those to fill out the evaluation survey. You could do that while we're still talking if you'd like. It only takes 1 or 2 minutes. That would be helpful. I'm going to ask a couple of the questions from earlier. How soon should you screen for post-stroke depression? Should you wait 3 months or?
Oh, that's interesting because I wonder if I can pull it up, Sue.
Mm-hmm.
So since we're on this, I'm just gonna see, because I think it says here.
Guess one of the reasons for asking is because, when is too soon? You know what I mean?
Yeah. So here, it says should take place before hospital discharge to the community.
Right.
And whenever, yeah. Can you guys see that?
Yep.
That's great. Okay.
If you want to leave that up, another question came in about what specific assessment tools would you use to screen for depression? I thought you had a slide in this one.
Yeah. Oh my God. So these are what they use for a mood assessment. This is what the social workers at Parkwood use.
Mm-hmm.
I had actually never heard of the GAD, so some of this was new to me, but this is kind of some of the more common ones.
Yeah, I know at HSN they use the PHQ-9 and maybe sometimes the PHQ-2. And I know our navigators in the post-stroke transitional care program use the HADS. So
Right.
just some
Yeah,
ideas
this
for
is
people.
inpatient. I think for
Yeah.
some of the other ones, there's different ones. I'm just anyway.
Okay, I'll keep going. Is it a specific part of the brain that is affected that produces depression, apathy, and fatigue? Could we know just by where the stroke happened in the brain or not? It could happen with any type of stroke.
Um, that's hard. That's hard to say because it depends.
Yeah.
I mean, depression can happen for so many reasons. I mean, people can have depression without having a stroke.
Right.
Um, and so I think it's difficult, but typically the ones where we see behavior change, as mentioned, were those frontal temporal lobes where
Right.
we see the
Okay.
emotional changes.
Okay.
Um,
Another question, Margot, is that okay?
yeah.
Yeah. Any suggestion on what to do with a patient frontal lobe stroke who is particularly mean and derisive to staff and family members? We educated the family and staff, but family members were still crying after visiting.
Yeah. It's so hard, hey, when people change, when their whole personality changes, and we talked about that whole thing around grief. But I actually had to go into a long-term care facility once because of someone that was experiencing those types of behaviors. It really is difficult, but I think it's when I talked to this particular family, the gentleman was kind of cantankerous before the stroke. And so things were just a little bit exaggerated. So that's why I said it's important to know what they were like before the stroke, because sometimes it just exaggerates what was already there. If it's totally new behavior, that can be extra distressing, but it can also be distressing for the person with stroke. So I think I think definitely pointing it out to them when they're behaving that way, that, hey, this, I do not appreciate you talking to me this way. Could you please lower your voice? I think making them very aware that they're doing it, because sometimes it's an immediate response and they don't even realize that it's happening, or that they're having that effect on people or impact.
Mm-hmm.
And then just letting the family know that it, again, providing that bit of hope around, if this is a change due to the stroke, that as time progresses and they become more comfortable in, with their changes, with their deficits, and as the brain cells, as that period of spasticity, that there's always hope for improvement. So I think we always need to leave them with that.
Mm-hmm. Yeah. And, most of us work on a team. And so it's important to reach out to all the team members to get ideas around behavior management strategies that can be used. I noticed you mentioned the rec therapists, Margot, thanks for the shout out. I always love that, but they could be there to help with finding activities that they can do, and then family can distract the person by starting to do an activity that they enjoy.
Right.
But there's all kinds of members of the team that could be helpful, right?
Yeah. But again, it's looking at those triggers, so that the person who asked that question with that gentleman, what is there a certain thing that's happening when his anger, like when he becomes angry and mean, is he having pain, those kinds of things. So I would really kind of look for some triggers.
Right. Good idea. You mentioned behavior management training as a possibility. Can you tell me who provides that, or where you might find that information?
I can't. I have never myself ever used it.
Okay.
I would suggest kind of just doing a Google search in your area for people who might provide that type of behavior training.
Okay, good. And then in terms of behavior, which chapter or release is it in the Canadian best practices? Where can you find behavior? Is it on its own? I can't recall. Or is it a part of a
Well, why
certain
don't we?
chapter?
I'll just go to that link. It should be I believe it's Oh, I don't want to guess.
You have to be in slideshow mode.
So we're in the recommendations, secondary stroke prevention, acute. Where did I find it?
Is it transitions lower?
There it is, mood, cognition, and fatigue. So there is a post-stroke depression and fatigue one, but there's also there was one. I know it's here somewhere, guys.
Okay.
Good.
At least we know it's that one full chapter for sure. So people can go to strokebestpractices.ca and then click on that recommendation.
Yeah.
To read about more information for sure. Is
Yeah,
there any other questions from the group as we're going to wrap up? Just going to watch the chat for any final questions and remind you that we've recorded this session. We'll be putting it on the Northeast Ontario Stroke Network YouTube channel for people to view. It should be up there later this week or early next week. We will send out the evaluation survey link, a certificate, and the handouts following the talk today. I'd just like to thank you, Margot, for joining us in the Northeast and for sharing your knowledge around behavior. It's a hot topic for us up here, and we're really happy to have somebody that could come and speak to us and give us some great ideas how you can help. I love those slides and also other websites that we can go to. So we really appreciate that you joined us today, and I want to thank you very much.
Well, thanks for the invite. Thanks for having me.
You're welcome. And I see no more questions, just lots of thanks in the chat. So we'll sign off for today, and I wish everybody a good day. Please stay well.
Yeah, thanks.